usually in lupus, it's very difficult at times to tell when somebody has an infection or somebody has a flare, because both can present with the same presentation. But we know that when patients have flares, one of the things that we really have to look out for is the presence of a concurrent infection. Work can induce stress, too much work at times, and there are certain occupations that when people are exposed to, they can bring about flares. And of course, chemical exposure. So certain chemicals are known to cause irritations, and this, especially with patients who have skin problems with lupus, this can be a very leading cause of flares. So how do we make a diagnosis of lupus? I think it's very important to state that making a diagnosis of lupus can be difficult. So it is not unusual for patients to come see Dr. A, and they will go through all the evaluation, and as people always say, somebody misses the diagnosis of lupus. So it is not an easy diagnosis to make. But usually when you present to your doctor, the way they will come up with a diagnosis is through a detailed medical history. So there are certain things in the history that will be suggestive of lupus. And after taking the history, it's important to do a physical examination. So there are certain pointers when the doctor examines you that will point to possibility of having lupus. Of course, there is the issue around tests, blood tests, skin and kidney biopsies. So these are very specialized tests that, and also some of the common tests that would give us pointers towards there being a possibility of somebody having lupus. So who gets lupus? So this data that I got from the US, and we know that anybody can get lupus. So looking at the US, there are approximately about 300,000 adults in the US who are living with lupus. So if you look at the population of the US, is about 400 million, that's about 10 times. So even in Kenya, if you can extrapolate this data, so we talk about maybe 40,000 Kenyans probably outside there who are living with lupus. But there are some people who are said to be more at risk of having lupus. So for example, women during the reproductive ages, 15 to 49. It is documented that certain ethnic groups and races tend to be more at risk of having lupus, so or having more aggressive lupus. So like in the US, African American, Hispanic, and the Asian, and the Native American descent. Then also people with a family history of lupus or any other autoimmune disease. These people tend to have a higher burden of lupus compared to people who don't have such kind of family history. So what happens if you have been diagnosed with lupus? What we know is that people's experience with lupus can be varied, and lupus has been known to have a serious impact on the quality of life. So there is usually that emotional stress of having a diagnosis, but also the burden of the disease. So this can lead to serious impact on quality of life. So lupus patients tend to have a higher risk for other health conditions, which include cardiovascular disease, diabetes, and kidney disease. This is partly because of the disease itself, but also, as we said, the inflammation that is brought about by lupus can cause damage to many tissues. So for example, in the heart, the blood vessels, and this would lead to a very high cardiovascular disease burden. But very importantly is that while there is no cure for lupus, there is effective methods for managing symptoms and for treatment. But it is very important to note that early diagnosis is key, because when patients are diagnosed early, then we tend to avoid some of the damage that does occur, which at times can be very difficult to manage. But reassuringly is that researchers are not sleeping and research is ongoing. So I think the future is bright for people with lupus. So I think my 10 minutes are done. Dr. Tao, thank you very much.
Thank you very much, Dr. Fred Otieno, for that excellent presentation and overview of what lupus is. And we'll leave questions to the very end of our presentation. So allow me to now invite Professor Oyo, who I think is online now, to give us his short talk, after which there might be a change in the program a bit. We'll go to the patient's experiences, and if Dr. Owino Congo does not join us later on, I will do a short presentation on the pediatric lupus. Kindly allow me to now invite Professor Oyo to speak to us.
Thank you very much, Dr. Itau. And I really don't have a talk. Mine was just to do introduction. And I would want to welcome all of you to today, the World Lupus Day this year. This is a special day for lupus patients and their caregivers, especially the caregivers. And it is celebrated every May 10th for the past 17 years. That's when I became a rheumatologist, there was still no Lupus Day, and it came there in between. And the idea is to raise awareness about the symptoms and the health effects of lupus. Dr. Tino has told you the difficulty of making diagnosis of lupus. Lupus Day is not just for patients and caregivers, but even for health workers. We need to educate health workers so that they are able to have a high index of suspicion and make an early diagnosis of lupus, because early diagnosis is leads to good outcome. In this year, especially in 2021, we are making lupus visible to the public by using the power of social media. So we want to encourage all patients, all health workers, all caregivers to use the social media to educate the world about this important autoimmune disease. And it's a day that we are calling for more research, greater public awareness about lupus, and availability of the support services that can be offered to those who are affected. And that's why I'm very grateful to the administration at Kenyatta National Hospital for hosting this year's World Lupus Day for all of us and all other supporters. Welcome. We have good speakers who will bring awareness, as will be outlined by Dr. Itau. And I hope that you will enjoy the World Lupus Day, and that the awareness raised here today will lead to better management of patients, early diagnosis, and better outcomes and good quality of life, not only for patients, but for the families that have patients with lupus. Thank you very much, and may God bless you. Dr. Itau, you can go. Dr. Itau. The next speaker was supposed to be Dr. Owino Congo on Lupus and Children. I don't know if he's around.
Prof, Dr. Owino seems not to be on. And what I'll request Nelson is to share the presentation by Rachel, one of our patients who has lupus. Subsequently, we'll move to Veronica from the Patient Support Society. But the next presentation will actually be mine. If it's okay, I'll share my screen and do a presentation on the COVID-19 and lupus.
Yes, welcome then. I think those who missed this one in children will come in the evening when Dr. Angela will talk about the same in children. Thank you.
Thank you very much, Prof. Welcome all. Happy World Lupus Day. And the theme is Together We Can, Fighting Lupus Together. So we join together, we join hands together to fight this disease. And today is World Lupus Day. My talk is on COVID-19 and lupus. We are living within this pandemic at the moment, and it's an important bit to talk about, and it's been a great challenge for us, this COVID-19, both for all the for everybody within the country, globally, and also our patients who have lupus. Patients who have systemic lupus erythematosus have increased vulnerability to COVID-19. There are several papers that actually do point to that, and the American College of Rheumatology now recognizes that patients with lupus have an increased vulnerability to COVID-19. And with this in mind, of course, then therefore they should be prioritized for COVID vaccine. And at the same time, it's noted that patients who actually lupus have a risk of developing serious complications, especially those who have comorbidities. And unfortunately, these comorbidities are still present in patients with lupus: high blood pressure, diabetes, renal involvement, and obesity. Some of these might be coexistent, or sometimes may occur because of the disease itself, or as a complication of the treatment, especially steroids. But fortunately, what was found that these serious complications from COVID-19 were not related to the immunosuppressant medications, which was reassuring. Now, patients with lupus then need to continue and still adhere to the COVID-19 prevention measures, which include wearing masks, avoiding public gatherings, hand washing, sanitizing. So basically all these measures to ensure that they decrease their risk of developing lupus. And the other bit that I did not put here, of course, is vaccination, which has also been shown to be helpful, and I'll speak about it in a short while. One of the things that at the beginning of the pandemic, there was thought that it was protective, and we found it is not, is that hydroxychloroquine actually is not protective, and people are thought that patients with lupus therefore will be protected because they are on hydroxychloroquine, and this was not true. And patients with hydroxychloroquine actually did develop lupus, and unfortunately some of them ended up dying. The other bit about COVID-19 for everybody, and including actually our patients with lupus, is the mental health. COVID-19 has actually affected many of us mentally, because usually patients with lupus have a feeling of being alone, because the feeling is that you have this illness that is affecting you, and it's affecting your life, your quality of life, your enjoyment. And now there's a new disease that comes and tells you isolate, get away from people, and this can create a feeling of loneliness or abandonment. And this may lead to mental health issues like depression, anxiety. And one of the things that is advised for all of us actually during this COVID-19 period is to, though even if it's not physically, but to continue talking to our friends, continue being part of our support groups, and if necessary, get mental health specialists to support us, counselors, psychologists, and psychiatrists if possible. But COVID-19 actually has led to lots of loneliness and has led to an increase in mental health issues. So it's important to also remain mentally healthy during this period. The next point that I'll speak about is COVID-19 and vaccination. And vaccination is important because it decreases the risk of infection. Many people ask, why do you need to get vaccinated? Actually, it will decrease your risk of getting the infection. It will decrease the risk of developing severe complications of COVID-19. And people who are vaccinated actually have a lesser risk of death from COVID-19 or admission to ICU or requiring oxygen therapy. Of course, once you're vaccinated, also you have decreased risk of transmitting the disease to your family members and to people that you're with together. More than 61% of patients with rheumatological conditions, when they were surveyed, were actually willing to be vaccinated, and that is good. And this increased, of course, when us doctors spoke to them. So there's a willingness within our patients with lupus and to get vaccinated, and that is important. And the advice remains that all patients who have lupus, unless there's a contraindication, should get vaccinated. Now, the catch will be the type of vaccine that we can use, and we shall have a discussion about this. Now, these are the type of vaccines that are available. In Kenya, we only have the Oxford AstraZeneca. We also had at some point the Sputnik, but it's the Oxford that's remaining. It has depending on the studies that were done, the efficacy is variable, but usually around 70%, between 60 to 90, but let's say 70%. And one usually will require 2 doses. Unfortunately, due to the increased the risk of thrombosis and low platelets, this medication is therefore within UK and the advisory change to be used for people who are above 40 years of age. That is a slight challenge for us because most of our patients in the lupus population fall below the age of 40 years. Because of that risk of thrombosis, and ideally, where other vaccines are available, then one should use the other types of vaccines. The other vaccines that are available, of course, is the mRNA type, the Moderna, the Pfizer one dose injection, Johnson & Johnson. We have the Sputnik, which is similar to the AstraZeneca one, which is a viral vector vaccine. And then we have the Sinopharm vaccine, which is an inactivated virus vaccine. WHO is currently in negotiation, I think, with the Sinopharm vaccine, and we might actually get more different types of vaccine coming to the country soon. The advice is that once you get one type, you should, and that requires a second dose, you should get the same type for your second dose so that you can get full effectiveness. Sorry for this busy slide, but this is it's a current ongoing survey of patients who have gotten COVID-19 who have lupus. It's called the VACOLUP, and its tolerance and consequences of vaccination against COVID-19 in lupus patients in full. And so far they have surveyed 571 patients, and majority of these patients, this is a global survey, have gotten the Pfizer vaccine. And as Prof has mentioned, we are going to do research. So one of the things I think we're going to do after this, maybe in the coming week, is to do our own survey of all the patients who have been vaccinated and see how many have developed any adverse effect. But in this survey, 571 patients were reported that they had gotten this vaccine. Majority had gotten the Pfizer vaccine. Of interest to us is only 10% of this had gotten the AstraZeneca. That's like 50 patients. And the majority never got any side effects. 46% did get some side effect, and majority of them actually said it was minor. So if you look at this statistically, most of the people who got the vaccine did not have any adverse effect, but self-reported adverse effect of the first injections to be moderate or severe, but this is self-reported. It doesn't necessarily mean that they got anything serious. After the second injection, the reporting of the adverse effect was actually more than half of the people who got the second injection reported more adverse effects. And but still majority of them reported them as minor. Of note, which is an objective part of this study, only 20 of the patients with lupus who got this, out of this 71, actually got doctor-confirmed flares. And there are only 3 patients who required hospitalization, which is reassuring to say that within all these vaccines, they are safe and patients should actually go to have the vaccine. The caveat, of course, is the current recommendation. This is based on the United Kingdom, where patients below 40 years of age are not advised to get the AstraZeneca vaccine, but they're advised to get the other types of vaccines. Now I will go through the American College of Rheumatology guidelines for COVID-19 vaccination, that patients with rheumatic disease, including lupus, there is no additional contraindication beyond known allergies. But like I mentioned, the UK suggests that people are below 40 years of age should avoid getting the AstraZeneca vaccine, which is available in this country, because of that fear of thrombosis and the low platelets and the formation of clots. That from the American College of Rheumatology guidelines, the benefit of vaccination actually exceeds the risk of developing a flare. And after vaccination, even after complete vaccination, one should maintain COVID-19 prevention measures. And this is important. I know people feel it's paradoxical, but it's actually important to continue wearing a mask, washing your hands, ensuring you decrease your risk of developing of getting COVID, and especially now that we have different variants of COVID-19 that are appearing in different parts of the world. Now, for our patients who have lupus, what medications do we need to modify around when we are going to get the vaccine? As advised from before, for methotrexate, we skip the next dose after the vaccine. So if one is on methotrexate, you continue with it. Once you get a vaccine, you skip the next dose. Prior, there was no advisory on mycophenolate, but currently there's an advisory that if you have one has stable disease, you hold the dose for 1 week after the vaccine. And the other bit for cyclophosphamide, the same. You give it 1 week after the vaccine dose. For rituximab, you get the medication administered 4 weeks prior to the vaccine, or 2 to 4 weeks after the vaccine. So for methotrexate, mycophenolate, and cyclophosphamide, it's a 1 week period. For cyclo, 1 week before. For methotrexate and mycophenolate, you hold the medication 1 week after the vaccine. The reason for holding these drugs is not because the vaccine will cause any illness in an individual, but there's a risk of the vaccine not taking and you not getting the adequate immune response because of this medication. The other, some of our patients are normally on non-steroidal drugs or paracetamol. The advice is to hold it 24 hours before the vaccine, but if one develops any complications post-vaccine, then they may use it. So remember, these vaccines do not cause COVID vaccine because none of them is a live vaccine. They are either inactivated or it's an inactivated vaccine or part of the vaccine that is carried by a virus which is not a potent virus in a human being that does not cause an infection, or an mRNA vaccine that therefore enters your cell, and from your cell then it produces a part of the protein that will be recognized by your immune system, and that your immune system will therefore be able to defeat the coronavirus. So the vaccine does not cause an infection the vaccine does not result in COVID in patients. I'm now done, and thank you very much. And once again, happy World Lupus Day. And mine is to request that we put the next presentation for.
Dr. Wino is around, so you can schedule him also.
Dr. Wino can actually go ahead and make if his presentation is available, he's welcome to present it.
Dr. Wino can load. It has already been promoted to a panelist, so he can share his screen.
Thank you, Prof.
Okay, Owino, go ahead. Owino is a rheumatologist in Kenyatta National Hospital and in the Department of Pediatrics and Child Health. Go ahead, Dr. Owino.
Okay, good afternoon.
Good afternoon.
Okay, thank you. Oh, my slides are not moving. I think I need to stop. Let me stop share and share again because my slides seem to be frozen.
Okay, that's all right.
Yeah. Okay, good afternoon. Thank you very much for the opportunity to share something on pediatric lupus. And as the previous speakers have said, happy World Lupus Day, and care for lupus so that we can save lives. So I will briefly look at some of these issues, but some have been addressed by Dr. Itau and Otieno, so I will skip the ones that have been addressed so that I don't repeat. So the first question I would like to answer is how common is lupus in children? We've already seen that lupus occurs worldwide, and it appears to be more common in people of African descent, and as a result, certainly lupus does occur in Kenya and in Kenyan children, and probably more commonly than it occurs in children in Caucasian and other ethnic descent people. Predominantly affects females, female to male 2 to 5, prior to puberty, and female to male 9 to 1 in reproductive years. I think the importance of this slide for us and for me is to just stress that males or boys also get lupus, and therefore it should not come as a surprise to anyone, because I think previously maybe the notion has been that it is only in women or in girls. It is true, it is more common there, but it does occur in boys and in men. So our population projected at around 50 million, and it is estimated that lupus occurs in 3.3 to 9.7 per 100,000 children. And based on this, we estimate that there is not less than 960 cases in children just aged between 5 and 19 years. However, this is a slide that one of our postgraduate students extracted from the registry in Kenyatta National Hospital. And we had about 55 children seen between 2018 and 2020 who had lupus. And look at the age distribution. We actually had quite a number, about 10 who are below the age of 5 years. So it does occur in all age groups. This slide also was shared by one of our postgraduates, of course, from the place that I've acknowledged there, just to show the incidence and prevalence, or in other words, how common lupus is. And that includes adult and pediatric lupus. Not very good appearance for us because we are blank to show that there's no data. And the importance of this is just to ensure that all stakeholders, including patients and their parents, do support us in research if and when we do approach them, and the other stakeholders to support whether in terms of financing and the other logistics to enable us to populate this map so that we don't appear blank. So causes of lupus, I think Dr. Otieno already alluded to. But like all autoimmune diseases, if a close family member has SLE, then or another autoimmune disease, then the individual child or person we're talking about has a higher risk of, or higher chance of having lupus. And therefore, it is important if a family member probably has lupus and a child manifests some of the symptoms that we already talked about in the previous presentation, then they are actually taken early for a diagnosis or assessment. And children are not just little adults. Lupus often manifests differently in children. Even though in a good number of adults, the disease might be mild, in children, it's almost always very severe. And we have very, very high involvement of the kidneys and the brain. And these are the two main organs that, when affected, determines the outcome of the disease. So we can see that children are at much higher risk of getting very severe disease, being admitted in hospital, and being given more aggressive treatments that may also obviously have some side effects in their body. and above all, they are at higher risk of death. Diagnosis is based on the signs and symptoms as discussed by Otieno, but I wanted to just allude to some of these laboratory tests, so because often we ask for them and sometimes people may not understand why we are asking for the tests. Once we've seen that a patient manifests with any of the clinical features that are on the left, or which Dr. Otieno talked about, then we do ask for these antibodies, which helps us to confirm the diagnosis of lupus. And it's a bit unfortunate that whenever we ask for these antibodies, it takes upwards up to 10 days or even 2 weeks before we get the results. And sometimes it's very frustrating. And I think this is an area where we need support from various stakeholders, including the hospitals and the health facilities where we work, so that we can be able to investigate our patients in a timely manner and start treatment. Because I don't believe that we should keep a patient for more than 2 weeks once we have already suspected the disease before we start treatment, just because we are waiting for some of these tests. Unfortunately, that is what is happening, whether in the public sector or even in the private hospitals where we sometimes work. So I think this is an area for advocacy to see how we can improve on the testing turnaround times. Otherwise, the patients keep suffering while we wait for the results. Those are just some of the pictures to show how the disease manifests, but I think Dr. Otieno had already covered this. Again, whenever patients come to us, we often ask for several tests, and it is important for patients and also for our various stakeholders to understand why we ask for these tests, because we do understand also they cost money. We need to assess how active or how severe the disease is at each and every visit, and therefore we may actually ask for some of these tests. And I think ESR is an important test, but almost all our laboratories, whenever you ask for ESR, especially in the public sector, many times they are not giving us the results. And it's an area for all of us again. I think Prof. Oyo put it very well that the World Lupus Day celebration is for awareness creation, both for patients, caregivers, as well as for health personnel. And I think that is mainly directed at our healthcare personnel. Whenever we ask for ESR, kindly give it to us because we need it to help in assessing the disease activity. In terms of management, again, Dr. Otieno had alluded to, but I would just like to say that we have the personnel and the requisite infrastructure to manage these patients. Sometimes we have some of our patients going out of the country only to come back with the same treatment. I had a patient that left, for example, after we had diagnosed, and they came back on methotrexate, which is something that we have here and is easily accessible. But all patients are, of course, entitled to second opinion and to seek care wherever and whenever they want. But I think we should just have a faith and confidence that the personnel that we have in Kenya and the availability of all the treatment is as good as you have anywhere. The last thing I want to say about drugs is that we have almost all the arsenals, all the drugs that are required for management of lupus. But some of these drugs, for example, rituximab, which is the biologic there, and mycophenolate mofetil are extremely expensive and sometimes out of reach to many of our patients. And therefore, it is an area for all of us to come together to advocate for support, especially from the health insurers, up to and including our public health insurer, NHIF. Many times they do support, but I think the process of getting that support is not very clear and sometimes tedious, especially for patients who are not very well versed with the processes. The outcome of SLE has improved over time. However, childhood SLE, as we said, usually manifest with very severe disease, especially involving the kidneys and the brain. And the involvement of these two organs determines how well the patient will do and determines mortality. And unfortunately, almost all the children that present with lupus present with kidney involvement and a good number with brain involvement. That means the outcome is much worse for children than adults. And sometimes we have to give more aggressive treatment for children as opposed to adults. So don't just compare. Sometimes you may know an adult who is on some mild medication, and when it's a child, they're given more potent medications. And then for those who may not understand, may think that we are being too aggressive, but that is because the disease itself is aggressive. So the last comments are on effects on daily life. School, normal schooling, attendance is encouraged. There should be no limitation on sports, but you can reduce high impact sports, especially if some of these blood parameters we call platelets are low, because you can bleed in the brain. Normal diet is recommended, and avoid sun exposure, use sunscreens or even protective clothing. Vaccination has already been talked about, but HPV specifically is recommended. And therefore, because many of the children who have lupus are adolescents, and that's the age group for which we have a routine immunization, make sure that they are all protected. And of course, the other ones who may not be in that age group should also access the vaccine. Live vaccine should be avoided, including in patients, in household members. And this is important because very soon, I think before the end of this month, we are going to have an oral polio vaccination campaign once more. And children or even others who live in the households with patients who have lupus and are on immunosuppressive therapy, the children living in those households should actually not receive the oral polio vaccine. COVID vaccination, Dr. Itau has already covered. So where can we access the services? These hospitals have at least inpatient specific pediatric rheumatology services. But of course, we have rheumatologists all over Kenya. Thanks to Prof. We have really expanded the number of rheumatologists in the country. We have Mombasa, Eldoret, Kisumu, and Nairobi, at least currently. These are areas where you can access rheumatologists. However, for pediatric rheumatologists, you can access in Nairobi only at the time frame. And of course, however many the rheumatologists are, just visit your healthcare provider and have any discussions. And where need be, you will be referred to the nearest rheumatologist. And if required, then you can be referred to the pediatric rheumatologist. Thank you. And these are additional resources, because I think it's very important to know where to get reliable information. Please do not just go to Google, because Google has the good and the bad. For pediatric rheumatology, especially for lupus, we recommend that you go into this website called PRINTO, which is an international body which we are members of. And to finish with this quote, that the butterfly is proof that you can go through a great deal of darkness yet become something beautiful. That is to say, even for those of our patients who have lupus, despite the difficulties, it should never ever really suppress your goals, and you should go for it and achieve just like any other person that does not have lupus. Thank you, and happy World Lupus Day. Dr. Itau?
Yes, thank you very much, Dr. Owino. Great presentation. Very well highlighted on the issues of lupus in children and the main difference between them. In fact, many times people wonder, Dr. Owino has put a child on cyclophosphamide, and yet in adults we don't do that. It's actually because of the difference that lupus in children is much more severe than in adults. Thank you very much, Dr. Owino. Now we'll move on with our program, and the next speakers will then come from our patients, Rachel, and from the Patient Society, and subsequent to that, we'll get a presentation from Wilfredo Otieno, the Chief Physiotherapist. So mine is to request the host, Nelson, please share for us the next presentation. So Rachel. Rachel Wanyoike?
Yep, I'm here.
So welcome. Rachel is going to lead us in this session. She will introduce herself. She's somebody I've known for a long time, a great fighter, CEO of a strong institution. And though she has had lupus, she has not let lupus lead her life. We are hoping to be invited to a wedding soon. That's said like that. So, welcome, Rachel.
Thank you, Dr. Itao, and happy World Lupus. Also for the friends and family who were not able to join us today. As Dr. Itao mentioned, my name is Rachel Wanyoike. I work in the development sector space. I'm the managing director of an organization that works with farmers in the agriculture sector. Could I please have the next slide? So for purposes of my presentation, I thought to keep it very short, but really to just give you a bit of an overview about what my journey has been since my diagnosis with lupus. As most lupus patients will let you know, it doesn't always end up just only being lupus, but for purposes of World Lupus Day, that's what I'll mention. But in actual fact, I have been diagnosed with mixed connective tissue disease at this point. So in terms of my diagnosis, it actually happened a bit later in life. I was diagnosed in my mid-20s. I'm now in my 30s. And was very unexpected, and it arose based out of very unexplained symptoms. As Dr. Otieno mentioned in the beginning, I started to feel a lot of fatigue. There was pain, there was swelling, and it wasn't even something that I could actually explain. Because throughout most of my life, I was a very active teenager. I was in a lot of sports teams, and I couldn't understand what was happening. So in terms of the journey itself, it actually started with me seeing Dr. Itao in the first instance to try and figure out what was happening. And similar to what Dr. Yu actually said, I do believe the early diagnosis that Dr. Itao gave me in the initial stages was essential in helping me handle the disease, but also helping me understand it a lot quicker. I think the biggest challenge sometimes when you hear some of the words, some of the disease names, you go and Google. And when you're searching for this, you obviously hear worst case scenario. So it was very helpful for Dr. Itao to be able to unpack the diagnosis himself and to actually help me understand the disease that I found out that I then had. Something that Dr. Itao possibly doesn't even know, not being able to believe, not being able to accept, I actually sought 2 more separate opinions. And a lot of that is really trying to come to terms with the fact that after being so long, feeling like you are in good health, these new symptoms come up and you're not sure. But definitely after the 3rd opinion, I accepted that I did have SLE. And since then, the journey has been positive and negative. As most lupus patients will understand, you don't only have one disease. So subsequently, after being diagnosed with lupus, I later on got diagnosed with scleroderma. I also later on got diagnosed with Raynaud's disease, and so on and so forth. And it's really taken some time for me, obviously, to try and pack all of that together, but also learn how to manage it and learn how to live with my disease. And I have found that in terms of managing my disease, I know Dr. Itao will probably say regularly taking the medication, but in actual fact, I think for my first point, I'd probably be saying the support that I have from my friends and family. Having people around you that are able to identify changes either in the way that you are, the way your body looks, the way you feel, the way your character is very helpful. Because at some point as a patient, you're too close to actually realize what your current situation is. So it is very helpful for a family member to say, wow, I think your face is a bit puffier than usual. Are you okay? You know, or noticing that you're maybe struggling through a particular activity and asking if you're in pain. And also, I also have an issue with photosensitivity. So my family members regularly reminded me to make sure I put my sunscreen on. So having that support system around you, I think, is essential when managing your disease. I think in addition to that, definitely regular medication. Having regular checkups with Dr. Itao, being able to assess how I'm feeling with the medication that I have, if there needs to be changes and so forth, I think has also been very, very essential with the work, with the kind of diagnosis and prognosis that I've had. In addition to that as well, I also tend to say as a lupus patient, being also alert to your body changes. I think sometimes we just push it aside and say it's just a fatigue, but maybe it's something different. So whenever your body is doing something different, always feel free to flag it to somebody, especially your primary physician. In addition to that, in terms of managing my disease, I can fully understand, especially the lupus patients, that some of your symptoms are joint pains, is still trying to keep active, even if it's a little bit, really just trying to maintain activity and really trying to keep healthy, eating right, and really trying to ensure that you're giving your body the best fighting chance by staying healthy. So in terms of managing the disease, it's not one magic pill, it's not one quick fix. It's really about how you operate. I think also one of the things that I found was a clear support system when I was diagnosed with lupus is actually the lupus community within Kenya. When I was diagnosed, Dr. Itao did encourage me to meet other patients that were in similar situations to me. And I think initially when you get your diagnosis, it sounds very bleak. It sounds like you're going to have to miss out on a lot. But being part of the lupus community, especially in Kenya, has been very, very helpful for me. And a substantial amount of this is because it shows the level of hope and it shows the beacons of strength that are within our specific community. I know previously we hear things that, lupus patients will be challenged to have children. And I managed to meet a woman who brought her son who was 18 years old. So that apparently was a challenge, but at least not insurmountable. We hear about people who perhaps get held back in their careers. I found a lot of women who had advanced in their careers. Some had even pursued higher education and had masters and MBAs. So it really shows that there's a lot of hope at the end of the tunnel. And at the end of the day, I think as lupus patients, really keeping that in mind at all times is essential to ensure that we're able to have a fighting chance against our disease. And I always tend to like to say that I'm not suffering from lupus, I'm actually living with it. And at the moment, all is well. I'm happy with my friends and family around me. And I'm also happy with the lupus community that give really great support to everyone. And it's been a great experience. And I think just in terms of my last words and my take homes for today, for the patients out there or the family members of patients, I think one thing that I would say is to be positive. Sometimes it does seem a bit bleak, you do feel unwell, but I think the one thing that you should always be is be positive. There is a light at the end of this tunnel, there is a way to manage it, and there is a way to live with it successfully. I think another thing I'd like to say, and this goes out more to lupus patients, is to be patient with yourself. I think there's sometimes when you feel tired, but you're trying to push through because you don't want people to think that you're being lazy, but your fatigue is your fatigue, you can't do much about it. And I think a lot of that is really part of our mindset. So as you push through, be also patient. And lastly, keep healthy at all times, stay active, and always tell your doctor when something different is happening with your body. But thank you so much for taking the time to listen to me today. I just wanted to share a little bit about my story, and I wish everybody a happy World Lupus Day. Thank you.
Thank you very much, Rachel. That was a wonderful presentation. Please stay on because you'll be asked some questions at the end.
No problem.
So thank you very much. Now mine is to invite Veronica Okello, who is a representative of Patient Society, Lupus Foundation, Africa, who are doing a great job in patient support, and of course in liaison with the medical specialist. And she's going to talk to us about the role of support groups for patients with lupus. Welcome, Veronica.
Thank you, Dr. Itao. Good afternoon, everyone. My name is Veronica Okello, a warrior diagnosed with SLE in 2012. In this session, I'll be speaking about the role of support groups. I'm a member of a support group called Lupus Foundation of Africa, shortened as LFA. What is the role of support groups? A support group brings together people who are going through or have gone through similar experiences. It provides an opportunity for people to share personal experiences and feelings, coping strategies, or first-hand information about the disease and treatment. A support group helps us engage with other people affected by lupus and learn tips from people dealing with similar experiences. For many people, a health-related support group may fill the gap between medical treatment and the need for emotional support. A person's relationship with a doctor or medical personnel may not provide adequate emotional support, and a person's family and friends may not understand the impact of the disease or treatment. A support group among people with shared experiences may function as a bridge between medical and emotional needs. A large inhibiting factor to patients feeling involved in their own healthcare is the model that focuses only on managing disease and less on promoting well-being. Support from peers, that is people already living with health conditions, could help fill the gaps. Instead of just helping combat the disease, peer support groups can help improve quality of life, improve outcomes, increase access, and improve efficiency in healthcare. A support group enables members to get practical feedback about treatment options. It offers better disease management. We know healthcare is heavily influenced by culture, setting, and population. Social interactions have a vital relationship to health outcomes. Medical culture needs to emphasize the importance of social relationships in disease management, health, and well-being. The medical model needs to be enhanced to achieve behavior change in patients, such as diet and exercise. There's evidence to suggest that people who attend illness-affiliated peer support groups better manage their chronic conditions and have better health outcomes than those who solely rely on medical interventions. Some support groups may offer educational opportunities such as guest doctors, psychologists, counselors, etc., to talk about a topic or topics related to the group's need. Peer support groups offer advocacy, assistance, and education led and managed by people living with health conditions. For people like them, traditionally, peer support groups are location-based groups that meet regularly, but an increasing number of online groups are expanding access to support. Peer support groups can offer real practical advice that the medical system is unlikely to bring up. For example, making a cup of tea in the morning to hang on to so that the hands can warm up and lose some of the overnight stiffness with arthritis, or how to have a conversation with your boss about a condition that they may never have heard of, such as lupus. This year, for example, LFA has arranged various virtual sessions in coordination with our rheumatologists. On 25th March 2021, there was a webinar on continued lupus care and COVID-19. We as warriors got an opportunity to submit questions in advance, and there was also a Q&A session at the tail end of the presentation. Some of the uncertainties we had as warriors on the impact of taking the COVID-19 vaccine vis-a-vis the various medication we are on were addressed. And this encouraged a good number of us who've already gone ahead and gotten the first COVID jab. This session today to mark World Lupus Day in the year 2021 is another example where LFA officials heeded the call and joined hands with various doctors and stakeholders to make this session happen. A support group helps in improving members' understanding of the disease and your own experience with it. A support group gives you vital social contact. Long-term illness can be extremely isolating. Some of our close friends may fall by the wayside when we are really struggling with the disease. Some best friends will understand your struggles. However, few can empathize and give you vital emotional support like another warrior going through the same thing. A support group is a place of empathy and understanding, not pity. Warriors can attest to the change in tone of conversations when you mention that you have a long-term illness such as lupus. A normal conversation will then retreat to, how? You don't look ill? You poor soul, you're so brave. I do not seek pity when I disclose my health status. I'm informing someone of a big detail of my life. Because if we work together or see each other regularly, my ill health will inevitably pop up at some point. The key difference from talking to someone who is healthy and someone else going through similar situations as you at a support group is they will offer you empathy rather than pity. And empathy is much more powerful than pity. Empathy empowers you to keep going using practical experiences. Pity is a transference of guilt. Someone else with the same illness can give you motivation to keep going like no one else can. To all warriors, remember, there is always someone going through the same thing as you. A support group is not a substitute for regular medical care. Life with lupus can be difficult at times, but it doesn't have to stop you from doing the things that matter to you. Many people with lupus live happy, active lives. You can too. In conclusion, I would like to reiterate an appeal that our doctors, the rheumatologists, keep making to us warriors and the leadership of the various support groups to unite. May 2021 be the year that all lupus and autoimmune support groups in Kenya unite. Excuse me. With one voice, we will be very strong at advocacy, and we all stand to benefit. Thank you.
Thank you very much, Veronica, for that excellent presentation that has shown why it's also important for patients to belong to the support groups and the work that you do. Excellent job to support the patients and ensure that the outcomes for our patients with lupus are improved. Asante sana. So our next speaker will be Wilfrida. Wilfrida Otieno Akinyi is a chief physiotherapist with the Ministry of Health. She has been very kind to patients with rheumatologic disorders. And at a time in Kenyatta, she actually was a resident physiotherapist with us at the rheumatology clinic. She's a great friend of rheumatology as a subspecialty. And she's, of course, a member of our society, the Rheuma Society and the Physiotherapy Societies. And we are very honored and humbled that she's gotten this big chair within the Ministry of Health. And congratulations to her, of course. And she's going to talk to us what is now her hot topic for the patients, disability benefits and tax waivers. Welcome, Wilfrida.
Thank you, Daktari. Good afternoon, everyone. I hope I'm audible enough.
Yes, you are audible, Wilfrida, you're audible.
Thank you. So my topic is about disability benefits and tax waiver. And so before we can talk about benefits and tax waiver, I think it's important we define what disability is and maybe go through the process of it all before you reach the tax waiver. Thank you. So defining disability, there's no standard definition and test for disability that is constant from one population to another. It differs from one society to another, and actually it keeps changing even from WHO description to other organizations. So the Convention on the Rights of Persons with Disability in 2006 defined disability to include those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full participation and equality in terms of comparison to the other normal people. Then the Disability Act of Kenya in 2013 described disability as a physical or sensory or mental impairment that includes visual, hearing, learning, and or physical incapability, which impacts adversely on socioeconomic issues on people or on the society, and also on environmental participation. Next slide, please. The background of disability, it's a complex and dynamic, multidimensional and contested topic. And it is an umbrella, it's a word, a big wide umbrella term for impairments or activity limitations and participation restrictions in the society. It refers to the negative aspect of interaction between an individual with a health condition and his or her environmental and personal factors. And so there are three different models to disability. The first model is medical model. Next slide, please. The medical model of disability is a consequence of health condition, disease, or trauma that disrupts the functioning of a person in a physiological or cognitive way. And so most of the doctors actually look at disability in the medical model. How does that disease or that condition affect you? And so this model conceptualizes disability as a condition or a person that, and focuses on the prevention and treatment or curing the condition that makes one disabled. The functional model, this model is similar to the medical one in that it conceptualizes disability as an impairment or deficit or inability. Disability is caused by physical, medical, or cognitive deficits. And so therefore, it affects function. Let's look for an example, a person who comes with a wheelchair for medical examination, for instance, and maybe the doctor doesn't have a bed that is adjustable to reach the level of the client on the wheelchair, then it becomes a functional limitation. The patient cannot come onto the bed for you to be able to assess. So the disability itself limits the person functioning or the ability to perform a functional activity. Next slide. The previous speakers just talked and said how we can marry the medical model and social model. So what is the social model? This model focuses on barriers facing people with disabilities. Instead of concentrating on impairments and deficits of the person with a disability, it now concentrates on the barriers and what we can do about those barriers. In this model, a person's activities are limited not by the impairment or condition, but by the environment and barriers and consequences of a lack of social organization. And so therefore, there is need for us to create a balanced approach in the weighted differences or different aspects of disability. So we need to marry the three different models, the social, the medical, and the functional model. Next slide. So causes of disability are many and wide and varied. Some of the causes are diseases, like chronic progressive conditions that we've just had, one of them being lupus. Congenital abnormalities are many. idiopathic disabilities that whose cause are not even known. Then there is malnutrition, that we lack some of the nutrients that we need, especially when children are growing up, that may easily cause disability. Like lack of iron may cause low calcium, and so the baby is having very brittle or weak bones, and so is not able to develop in the normal way that other babies do. Or trauma and injuries. We know a lot of road traffic accidents that cause disabilities. And then non-communicable diseases like hypertension and stroke cause disability. Ignorance. You find many moms with young children, and their children are not developing the normal way, are still waiting that maybe after 2 years my child will be able to walk, instead of seeking early intervention. So even ignorance can be a cause of disability. Then poverty. We find that most of our clients, or the people who live with disability, have socioeconomic issues that do not allow them to access healthcare the right way. And so in that way, before COVID came in, I know the Ministry of Health was working hard to bring universal health care onto board so that everybody can access health or primary health care. And then wars in different countries here and there, fights would cause disabilities through trauma or injuries like we had seen earlier. And occupational hazards do cause disabilities, like one of them, an instant was picking coconut from trees. People fall from those heights and actually have spinal cord injuries. And so some occupational hazards become a causative factor for disability. Next slide, please. So disability prevalence in Kenya today, in the 2019 census, we have 2.2% of persons living with disability out of the 48 million people. And in this number, unfortunately, the children below 5 years were not counted in the census. So that means that the number is actually much higher than the 2.2% that we are seeing here today. And the WHO has got 15% of the population having disability of one kind or another. So disability rates have increased due to the population aging and due to the increased non-communicable diseases. And then it is also increasing because the persons with disability have less access to healthcare services, just like I mentioned earlier, because sometimes they have mobility challenges, and so accessing health facilities becomes an issue. This is food for thought for us as health workers. And I think time is running that we need to think through how we can actually come from the maybe facilities, hospital setups, and reach out to the clients into the community. I hope this will come at some point or another. Next slide. So the WHO in 2001 classified disabilities into International Classification of Functions, the ICD-10. The ICF distinguishes between body functions and body structures and lists of environmental factors. So the body functions would be the physiological effects of the body, and the structures would be the anatomical parts of the body, and then the environmental factors that can be either personal or the surrounding in which the society and the community in which this person lives in. This more useful model of disability might be called the biopsychosocial model. It is a combination of the model of the medical model and the social model and the functional model. It's a combination of the three models that we've seen above. So ICF is based on integration of medical and social, provides coherent view of different perspectives of health, biological, individual, and social. So it is more comprehensive. Yes, this table is just showing a health condition like lupus, for instance, and how does that affect? Lupus affects the body functions and structures. We've heard about the joints, the fatigue, the headaches. Those are body functions and structures. Then that actually causes activity limitation. When one is unwell, then you are not able to perform the daily activities that you are able to do on a normal day. Some of the activities that we take for granted, for instance, just waking up from bed, getting up from a chair, sit and stand, fixing your breakfast, going into the bathroom, all those are activities of daily living. We do them without noticing a lot of the times until we are unwell and we are not able to make those movements and do those activities is when we realize that, oh, maybe something is not right in our system. So that activity limitation would cause participation restriction in a society. So if you are going to work and now today you have an issue, you can't even wake up from your bed, you can't move, then you'll not even be able to reach your workplace or go to school if you're a child going to school. So that would cause participation restriction. Then environmental factors are many, or rather, let me start with the personal factors are many. How do you look at your disease? Are you in a sympathy mode, or are you accepting that this is what is in me right now and I need to accept and actually take my drugs and move on, see a physician and do the right thing? And then the environmental factors. At your place of work, how does your employer view you? Is it accommodative for you to be in your place of work because the employer is understanding? Or the employer is feeling like this person is now no longer productive and maybe does not need to be with us anymore. So there are several factors around environmental factors that would affect us. Next slide, please. So in the environmental factors, there are several barriers. Like the barrier that we see here is this person who is on a wheelchair during the COVID-19 pandemic. Some of our measures was hand washing, and you can see how this person is struggling to access the water to be able to wash his hands. So an accessible examination table in the place of work needs to be created or needs to be available for people who are on a wheelchair like this person here. The matatu industry in Kenya today is not accessible for persons living with disabilities. A deaf individual without a sign language interpreter is equally having a barrier, like where we are in the clinics or where we work in the offices. Do we have access to somebody who can do sign language and interpret to us what somebody with hearing difficulties is going through? Then the stigma at workplace or schools. We know what has happened in schools before, that children with special needs sometimes are not accepted even in schools. So there's need of integration and mainstreaming disability into the society. So a wheelchair user in a building without an elevator or accessible bathroom or hand washing station has several barriers to face, even if he was to be in a place of employment work, all those will be challenges. Next slide. So this guy may equally perform like the rest of us, but because of those stairs, where he was supposed to reach was his workplace, he may not be able to access. Next slide. The Ministry of Health has tried to put disability into 6 big umbrella bodies that will be enabled to encompass everybody without leaving anybody behind. So disability was divided into 6 major domains: the physical disabilities, the visual disabilities, the speech, language, and hearing disabilities, the mental, intellectual, and autism spectrum disabilities. Those were the major ones that had been being looked into before. We are trying to bring others on board that we've seen people come into the office and have different issues that were not captured in the previous disabilities. So 2 of them have been added onto the 4 that were mainly there. So there's now dental and maxillofacial disabilities, and there's chronic progressive disabilities where lupus falls in. The document is still in the process of being developed, and so it has not been into place yet, but we hope very soon it will be operational. Next slide. So there are 3 tiers to disability. I'd explained earlier about activities of daily living, but the ability to take care of ourselves is measured by activities of daily living that most of us do without thinking at all. Until we can't, then the ability or lack, therefore, to complete each of these activities can foretell our fate. So we look at the 3 tiers to confirm that somebody has a disability that needs registration. And so those 3 tiers will be the presence of an impairment. If you suffer through a disease or condition, how does it give you, how does it limit you in the activity of daily living? How does it limit your performance? How does it limit your participation in the society? So we have the 3 tiers: the presence of impairment, the long-term recurrent, and the substantially limiting. Hello, Dr. Hello, I hope you can hear me.
Oh, yes, yeah, we can hear you. I was just reminding you about the time.
Oh, okay.
But please continue. Yes, thank you.
Okay. So lupus would be considered if symptoms occur repeatedly and the disease qualifies as a disability when it causes limitation of activities of daily living, limitation of social functioning, and limitation in completing tasks in a timely manner. Next slide. So lupus is not one of those conditions that can easily be seen. Until somebody explains to you that she's suffering from lupus, is when you can be able to say. So just like in this picture, some disabilities are physically seen, you can observe them. Others are actually invisible, you hardly can see them. Next slide. So disability registration process. The first thing that somebody who has a disability should do is go to the nearest level 4 or level 5 hospitals. Like in Nairobi, the Mama Lucy, the Bangadi Hospital, the National Spinal Injury, and the Mathare Hospital are the ones that are gazetted to do assessments for persons with disability. So that means that if you are in the county, then you have to look for a sub-county health hospital facility or a county referral hospital. Then that assessment is done by a team of a medical officer and the rehabilitation team. The rehabilitation team is composed of the physiotherapist, the occupational therapist, the orthopedic technologist, and the speech therapist where they are found. Then the medical disability form is then taken to the Ministry of Health for verification and concurrence by the DG. So if somebody has lupus, for instance, then that form alone is not enough. There should be an attachment of a rheumatologist report to the form. And the forms are then taken to the National Council for dissemination to the various counties. Next slide. Then the disability card is processed either sometimes in the national office in Nairobi, or the forms are taken back to the counties for processing of the disability cards, which are then issued to the owners in the regional office in the county. And so if you want to be considered to receive financial support, then you have to call the disability office in your county for recruitment, for when recruitments are done, because they have different benefits, and different benefits are given to different types of disabilities. There's the application for tax waiver, which is downloaded from the National Council of Persons with Disability and Kenya Revenue Authority website. This is for people who are employed and who have now been registered as persons with disability, and so they need a tax waiver from their employer. Next slide. So benefits of registration as a person with disability. If somebody has visual impairment or people who are on a wheelchair, they are allowed a 15,000 shillings monthly to facilitate a guide or a caretaker. Because we realize people who have visual impairments have difficulty in movement, so they can have access to a guide who is also paid, who is also equally paid by the government at a rate of 15,000 shillings. Then people who are registered for disability, they have an extension of retirement age from 60 to 65 for those who wish to reach that age. This is because a lot of times persons with disabilities go to school late, or even work, they may start work much later than the people who have gone through the normal path. Then access to government cash transfer for most vulnerable. This happens to people who, most vulnerable here are among people who have disability but are fully dependent on others to give them care. It's a cash transfer of 2,000 shillings per month given by the Ministry of Social Protection. Next slide. The benefits are also under the government procurement opportunities. There's 30% for people who live with disabilities or women and youth. There's tax exemption for the first 150,000 shillings, that is monthly income for those who are employed. And there's job placement to match the qualifications of people who live with disability in different job markets. Every ministry at the moment is encouraged to employ at least 5% of persons with disability among the workers or among all the employees in any given ministry, so that there is inclusion of persons with disability. No one should be left behind. Next slide. Infrastructure improvement is this is a benefit that goes to school, for instance, where there are no toilets that are wheelchair friendly, or fields that are not disability friendly, that can be improved so that persons who have disability can also actually participate. We were talking about participation restriction, and so this infrastructure improvement is to create access for persons with disability even in schools. The social protection is yet to come. It is at discussion level. They're trying to discuss about people who take care of persons with disability. How much help do they need in terms of emotional support, or even in terms of financial support? Like mothers who take care of children with cerebral palsy, for instance, the child may have access to the 2,000 shillings cash transfer, but what about that mother who is in constant care and may not even be able to go to place of work because of this type of duty that she has, that now she has to take care of a child who has disability? So this is ongoing, and it has not been implemented yet, but it will be implemented soon. Then assistive devices. Assistive devices are the items or the equipments that persons with disability use. These are like crutches here. We can see these people are in crutches. They are wheelchairs. They are glasses for people who have low vision. there are hearing aids, and there are different types of assistive devices. So if you are registered as a person with disability and you need assistive device, then through the National Council of Persons with Disability, you can access an assistive device through Association of Physically Disabled of Kenya, or at a given lower price with a tax waiver. Next slide, please. The benefits are many, and they continue. Training and capacity building from disability persons organizations to provide grants and entrepreneurship training for self-help groups for those who are not employed for their income generation projects. Then tools of trade can also be provided to people with disability who need to do different types of vocational self-employment. Then there is education and bursary scholarships given to children who are school-going, who may require support from the National Council, and they are taken through primary up to the university. Then for persons living with albinism, they have sunscreen, lotion that are provided to them. Next slide. So inclusion, access to services, we need to include everyone so that designs of buildings are designed in such a way that they can accommodate everybody, including those on wheelchairs or those on crutches. Mainstreaming disability across sectors, all ministerial departments, access to health, education, building and transport, social protection and labor, and a sign language translator should be everywhere, in the hospitals, in the emergency department, in the clinics, so that people with the hearing issues or communication issues can actually be at par on what is ongoing. Next slide. So in the Ministry of Health, some progress has been made towards accessibility of services to the persons with disabilities. A ramp and 2 washrooms has been done or constructed at the disability office. And then the guidelines are in the process of adoption and validation. We hope that they'll be out there soon so that everybody can be accommodated. And the disability policy is in the process of being finalized. And so a lot has gone on about disability. And for those who didn't get it clearly, you can go to the National Council of Persons with Disabilities website or Kenya Revenue Authority website to check on the benefits that persons with disability have across there. But you must be a registered person first before you can benefit through those facilities that are available to persons with disability. Thank you. That was my presentation. Next slide. Thank you.
Thank you very much, Elfrida. Much appreciated for your excellent presentation. Dr. Simani is the next speaker. Unfortunately, he is not able to be here with us. So you'll indulge me in making a presentation because whatever he was to present was healthy lifestyle in lupus, and I think this is still important. So kindly allow me to proceed and make this presentation. Okay. So healthy lifestyle is important in patients who have lupus, and a healthy lifestyle will encompass as one of the points exercise. And exercise is quite important because sedentary lifestyle in patients who have lupus or even in general is associated with an adverse outcome. It leads to increased risk. And actually in patients specifically for lupus leads to fatigue. And the reason for fatigue is because of, it's called deconditioning, where you are not active And it leads to a vicious cycle where you get more fatigue, you don't exercise, and then increase in fatigue. Fatigue, depression, and physical fitness in studies actually done, and there was something called a meta-analysis which looked at various studies that looked at the role of exercise in patients with lupus and studied patients with lupus. We found that this fatigue, depression, and physical fitness improved with exercise-based interventions. Many exercises are recommended, usually aerobics. In those who have arthritis, non-contact sports to avoid like rugby and football, swimming, walks, jogging. In fact, a recent review found that walking, let's say if you walk for 30 minutes to 1 hour, is actually sometimes it's equivalent to a person who has been running for let's say 10 to 15 minutes. So walking in itself is one of those exercises that we don't recognize its value. But if you wear comfortable walking shoes and walk for 30 minutes to 1 hour, is as equal to somebody who has been running actually for half an hour if you walk for 1 hour. But remember also to graduate your exercises, start small and increase in the magnitude. And take breaks in between. And of course, don't overpush yourself. The best exercises and the ones that have been studied are the ones that are guided, usually by a physiotherapist or, where possible, a personal trainer. The other lifestyle bit is smoking. So smoking, I'll put it here so that in case anyone smokes, any patient who has lupus who is smoking should actually stop smoking, because smoking increases lupus disease activity, increases and leads to skin damage, and causes and increases the cardiovascular risk in patients. The cardiovascular risk that it leads to is smoking is associated with it's called acute coronary syndrome, heart attacks. The risk of heart attack in lupus patients is high, and smoking actually increases this much, much higher. And ideally, patients should actually avoid smoking from the beginning, or if they are smoking, then they should quit smoking. And any cigarettes taken actually is a risk factor. The more the numbers of cigarette sticks that one smokes, then the higher the risk as a result of this. In terms of diet, there is no specific diet for lupus. What is been proven from various studies is a healthy diet, low salt, plenty of vegetables and fruit, decreased portions of starch, and use of polyunsaturated fats, because the monosaturated fats have been shown to be to increase the risk of cardiovascular diseases. Omega-3, which is a polyunsaturated, found in some polyunsaturated fats, decreases disease activity. And this is usually found in fatty fish. So that is one of the things that one may take, or one may take a supplement, but ideally one is able to get it in the diet. The other bit is nuts. They are also associated with low disease activity, and they have been found to be a useful part of the diet. The best for patients to do or one who is interested in diet is actually come up with a food diary, especially for lupus patients, and to see which particular foods when they eat is associated with flares. And this now leads to an individualized sort of food intake, where you note the foods that cause a flare and therefore you avoid them, and then therefore prevent future flares as a result of a diet. The other bit is to use alcohol where if one must, or if one uses, but use it with limitation, and to use alcohol equivalent to 2 glasses of wine for men and 1 glass for women. The other lifestyle aspect is avoidance of the sun, and usually avoid the sun typically between 10 to 4 p.m. and wear a sunscreen, at least sun protection factor 30. And when going outdoors, of course, wear a long sleeve clothing that protects your upper arms and legs, and wide brim hats. The other lifestyle aspect is to avoid infections, and where this is not feasible, to recognize infections early and have them treated. So if possible, avoid people who are unwell, whichever illness, sometimes, of course, limiting the visits to hospitals. These times of COVID, of course, and even if COVID comes to an end, to continue washing hands. If one is going to see somebody who has a respiratory disease or one has a respiratory disease, to wear a face mask. Important to have good food hygiene, to ensure that you have a clean living environment. It's important to get vaccines. Of course, there's the COVID-19 vaccine now, but typically, patients ideally should get annual influenza vaccine, at least a pneumococcal vaccine, and a booster maybe in 5 to 10 years, and get a vaccine for herpes zoster amidst the other vaccines that are available. And the most important thing actually is once one is unwell with a suspected infection, please do not stay with this infection for long, waiting for it to subside. One should actually get treatment and get treatment early. The other bit, of course, is mental health, the importance of stress management. Veronica talked about support groups and Rachel. So this is important, role of support groups, friends and family support, the role of exercises that I mentioned, the role of prayer, meditation, activities like yoga as exercise, pacing yourself within activities that you do, be it at work, be it in at home, or whatever activities that one is doing. And also to remember to take rests, which is part of the pacing, and breaks. That is actually important to maintain your energy and also to decrease the stress. And once again, thank you very much and for joining us for this World Lupus Day. That's the end of my presentation. And mine now will be to invite my colleagues, Dr. Sophia Dokwe. Dr. Sophia Dokwe is a rheumatologist. She's based in Mombasa. She's doing great work there, taking care of our patients. Of course, I'm participating in training and research, and we are honored to have her here today. She will lead the Q&A session. The other one is Dr. Eugene Genga, also an awesome rheumatologist, a lecturer with the University of Nairobi, a teacher, a researcher, an excellent clinician, who will also join us and he will lead us in the Q&A sessions. So Dr. Dokwe and Dr. Eugene, the floor is yours. Karibuni.
Okay, we appreciate the organizers for organizing for the World Lupus Day. And it's time for the Q&A now. We have a few questions. And there are many questions on disability. And there's a question that from Millicent, who is asking whether the Kenyan government acknowledges lupus patients as a disabled group and what is being done about it. Maybe to you, Elfrida.
Thank you, Daktari. Just like I'd mentioned earlier, the chronic progressive conditions were not included in the type of disabilities that are being registered. But like we had said earlier, there are 3 tiers for you to qualify as a disability. The condition must have been long-term and must be recurrent and must be limiting in the activities of daily living. Yeah, so if those 3 tiers are there and there's a support from your doctor, the physician, then you can be passed as a person with disability. Thank you.
Anjeri has also asked about exercise. And I think Dr. Etao, maybe you can talk about this. How much exercise is too much and how much is just enough for the patients? Or anybody else can take on that.
Can I help?
Yes, you can, please.
Okay. there is exercise prescription, which is individually based for each given patient or client according to their capability. So just like I think Dr. Tao had mentioned, the exercise should not be too much or not too little. And this goes by listening to your body. If you're able to do a given regime of exercises, especially from a physiotherapist, and then you also listen, do they make you too tired? If the exercises make you tired, too tired and sore for the next like 3 days after you did them, then you know that you did too much. So you need to reduce. So if they make you feel better and more relaxed, then you know you are at a good space. Thank you.
I think the secret is to pacing oneself. Most people have to listen to their bodies, isn't it? So the next question is about, someone had asked about COVID-19 and the warriors. They want to know about the COVID-19 vaccine, what to do. But I think Dr. Etao had talked about this. Maybe he can just remind them in summary, just what needs to be skipped, you know, just as a reminder.
Thank you very much for this question. The COVID, now one of the challenges is that if you go by the advisory from the United Kingdom government, where AstraZeneca vaccine is produced, they do not vaccinate individuals less than 40 years of age with the AstraZeneca vaccine, which is available in Kenya. So that's one of the challenges. The second bit is that, as we mentioned, the drugs, if you're on mycophenolate after the vaccine, you skip 1 week. Methotrexate, you skip the next dose after the vaccine. Cyclophosphamide should be avoided 1 week prior to the vaccine. Rituximab should be avoided 1 month prior to the, you get an injection 1 month before the vaccine, or if you have gotten the vaccine, you wait for 2 to 4 weeks prior to the next injection. Avoid the anti-inflammatory tablets or paracetamol the 24 hours before the vaccine. Once you get the vaccine, if you have any issues, then you can you can take them. So that's what I will say going by those advices. But the advice, I think for the other age groups, then and what we have as AstraZeneca vaccine, then one should actually go and get vaccinated. The issues of clots, nobody has actually identified patients with lupus or rheumatological disorder to specifically have that as an increased risk. So that at this particular time, one cannot comment on that. But the advice then because of this clot is that because of the risk of it, then individuals younger than 40 years of age, where possible, should avoid the AstraZeneca vaccination. Thank you.
Maybe while on the same note, Dr. Etao, you can also talk about the intermittent fasting. There's one of an anonymous attendee that has asked whether intermittent fasting can aid in alleviating lupus symptoms.
There's no specific evidence to show that intermittent fasting can elevate lupus, but there's evidence to show that intermittent fasting leads to weight loss and alleviate and assist in blood sugar control in patients with diabetes. But I do not have any evidence to support this in patients who have lupus.
Perhaps one of the panelists who are patients can tell us about plant-based diet. There's usually a lot of hype about this. Has any of you had any experience in this, and maybe you'd like to share with other patients?
Maybe I can answer that. So you can hear me?
Yes, yes.
Usually the issue about plant-based diet is more to do with oxidants, and they even say that these foods that have got high in carbohydrates, the high saturated fat, the processed foods and everything have a lot of oxidants. They tend to favor more of the plant-based diet. So they say the plant-based diet has less of the oxidants, which can activate or worsen the lupus. But in terms of if there's any evidence that if that has been applied in terms of from textbook to practice, so far I think the evidence is not there. And I think the recommendation is more just to, one, eat a healthy diet, and then two, know your body. annoy your body, meaning that if you find a certain food doesn't go well with you, you tend to avoid it. Yeah. So,
precisely. Because then it usually elicits a lot of questions. Have you experienced any patients who've been on plant-based diet, just solely on that, and did they do well at all? I'm sure there are many patients who are really listening who want to know, they come convinced that, altering their diet is going to sort out all their problems.
I think the misinformation is that if you eat healthy and everything, the lupus will go away. But if you look at the science of the disease, there's almost very little in terms of any correlation with the diet. So I think there's a lot of misinformation out there. And I think such forums are very nice because they address a lot of issues.
Okay. All right, there's also a question on the use of probiotics. Do they help with lupus disease? And maybe anybody again can answer that. Maybe Prof can tell us about probiotics. He's been in practice for the longest. Is he online? Anybody else can take the question on probiotics?
Yeah, unfortunately, many of these, like the probiotics bit, of course, there's the gut, the role of the gut in causation of autoimmune disease, and therefore one will then allude that the probiotics should be useful. But is it something that is advised for doctors to prescribe for their patients or for patients to take every day? I guess that's an individual decision, because in our guidelines for treatment of lupus, probiotics is not one of the medications that we should actually prescribe for a patient. But looking at the sort of gut and inflammation and the rest, then one will then argue from that perspective that yes, possibly there's a role for probiotics.
Okay, thank you very much. Someone is asking you, Eugene, whether you've managed to consolidate the data about lupus patients.
It was a work in progress. The thing was, we had applied for a grant last year. We wanted to put up a lupus registry in Kenya. I was working with a certain professor from South Africa, Dr. Kala. Unfortunately, they rejected the grant. I've been trying now to redo the grant again, and I'm hoping maybe this year I can apply again. And from the grant, I'm hoping that we can able to set up a lupus registry. So the role of the lupus registry have as many patients as possible, lupus included in the database. And from there, they'll be able to follow up what medicine they're taking, how they're doing, their life. In short, they're able to do more research based on the register data. So I'm hoping maybe this time around might be a bit lucky.
Okay, thank you, Eugene. Maybe you can also tell us about the relationship between lupus and nerve pain.
And nerve pain.
I know many
Okay.
patients present with neuropathies, yeah.
So if you look at the science of the disease, it's an autoimmune disease, meaning there's a foreign immune system where the police cells, I'm sure, has already been covered. So the essence that it can affect any part of the body, and the nerves is one part of the body that can be affected. If it affects another part of the body, it can present in a number of ways. One way it can present is through people complaining about tingling, some burning, sometimes can come the shock like electricity going through my veins. Some of these I can prevent. The other flip side to it is that you can also, in other forms of nerve pain, could be in terms of the discourse of fibromyalgia. Fibromyalgia is actually a chronic pain condition that can come in the background of lupus. We've seen a number of patients who have lupus and have fibromyalgia. There are a lot of nerve issues.
Okay, I have a question for Veronica, who discussed about the role of support groups. I don't know how often you're able to, as you said, you meet the medical, you bridge the medical and the social, and the emotional needs of the patients. Do you have cases of patients who've actually, gone through like, divorce, for example, just because they have been unwell for so long? And how have you gone about it? Do you deal with such cases? Has it happened?
Okay,
Thank you. Okay, in the support group that we have, there are various, there's actually a counselor who's part of the support group that we have. So should any of the warriors have any personal matter that they need interventions of a specialist, then they're able to chat separately with the counselor who is part of the group. So things like divorce and the like are quite personal, and it's not something that somebody would just maybe air out in a common forum, because the main platform that we use is WhatsApp. So as much as there are those instances where relationships have not survived because somebody has gotten very ill, we do have a specialist in the group, and should anyone need any interventions of a specialist, there's a counselor who's part of the group. Thank you.
Okay, and have you had maybe cases of abandonment where people have been sick and they've actually been abandoned at the point of their sickness and they have no one else to deal? Have you experienced such?
Also within the group, there are cases where warriors have shared their experiences where they're struggling and their family members are actually not able to come through for them, and they're struggling to bring their family members on board to really understand what lupus is. But beauty of having the platform is they receive encouragements, and time and again, members of the group have tried where they can best to support someone. People will engage you separately, give you encouragement, and those who are close to where that person is, some actually arrange to visit them.
Okay. Another question again for you. I'm sorry, Veronica. Are you encouraging the patients to, get like universal healthcare, like NHIF? Because as you have heard from the speakers before, that some of the treatments are actually sponsored by NHIF. And we do tell these patients to get NHIF when they come to our offices. But you see 3 months later, they come, they've not registered. They come again and they've not. And you want to help this patient, it will help ease their pocket. So are you playing a role to pass this message that all patients should actually be registered with NHIF?
Okay, the bit of encouraging every warrior to play their part as much as they can and do their level best to try and ensure they have some sort of buffer, even if it is NHIF, or if they're lucky to be employed and insurance from their employer. We keep encouraging, but at the end of the day, the action remains yours. So as a warrior, I can encourage another warrior, but in terms of implementing, the ball is solely in their court, because as much as I encourage and maybe share the benefits or how I have benefited from being a member of NHIF, the action remains yours. But there's a lot of encouragement in the platform, and time and again, we discuss various matters. So people do present the challenges they're facing, and there are cases where people go an extra mile and try and help where they can. There are instances where, for instance, somebody who was on certain medication, they had their prescription for the month, and maybe a few weeks down the line after they do their review with their doctor, some of the medication, they're weaned off that medication. People normally post and say, I have a tab of 10 tablets of this, who is in need of this? How can we meet? And I donate. So there's a lot of benefits in the group.
Okay, there is a question from Millicent asking about rheumatoid arthritis and lupus symptoms, as to whether, I think she's unclear about those symptoms and should love to have some clarity on how the two, I think, present, and effects of back pain in relation to the two. So I don't know, Dr. Genga, you'll take us through that, because
So you've asked, sorry if I get it right, the difference between lupus and rheumatoid arthritis in terms of presentation, and then something about back pain.
Yeah.
Yes. So in terms of presentation, they're quite similar in presentation, but the main difference is how the rheumatoid arthritis primarily affects the small joints. It comes with pain, comes with swelling, vis-a-vis lupus, which can come with any part of the body affected, can affect the joints, muscle. Rheumatoid can do that, but primarily rheumatoid arthritis is mainly of the small joints and comes in both sides of the right and left. In terms of the tests, also the tests are a bit different. ANA, antinuclear antibodies, more in the lupus. Something called rheumatoid factor, and this is more in the rheumatoid arthritis. Management is a bit of an overlap because we share some of the drugs like methotrexate, hydroxychloroquine are used on both sides in terms of the management. The second question is, sorry, Sophie, you said what about the back pain? Sorry.
Yeah, how back pain is related to the two, you know, they both can present with back pain, or it might be independent.
So there are two ways you can do it. It can actually be dependent on its own. Depending on take, for example, if you have like a prolapsed disc or an infection, there can be on its own. Number two, it can be related. Take, for example, if the rheumatoid arthritis affects maybe your knees or maybe affects your hip, you can have something called referred pain where your back is affected. The same applies also to lupus. If you have another joint, most of the time you have joints like the knees and the foot. There's a correlation the knees and the foot and the back. So a problem in one can cause pain, as we call it referred pain. That's some of the ways you can present. So you can either be independent or can be part of the disease. I hope I've answered, Sophie.
Yes, you have. Dr. Ekchau, maybe I can, just for the sake of the patients again, what have you seen is the general prognosis for patients with lupus who get COVID-19, you know, just from local practice, not from papers? What has been your experience, just to encourage the patients because they're listening, because they may get, they may not get, but you know, what can someone think, you know, get from this presentation?
Yes, majority of the patients here who have gotten COVID-19 have recovered and they are well, and there are even some in the forum today, I'm sure, treated by various of us. So that is great news. But also to say we have had a few patients who have gotten severe symptoms and have required much more aggressive treatment. And also, unfortunately, we have lost a few patients. But most of the patients, I can say about up to 90% of the patients so far who have gotten COVID recovered and they are okay. I hope that's adequate, Sophie. I'm saying majority of the patients who got COVID recovered and they're okay, more than, let's say, 90%. But we have had a few patients who have had significant complications and some patients have passed on.
I hope that is encouraging to someone there out. Okay, so there's also a question from Alice, who is, not Alice, an anonymous attendee who wants to know the average life expectancy of someone who has SLE.
Maybe I can take that. Initially, because a lot was not known about lupus, we didn't have the proper treatment, information was scarce from the etiology of the disease, and management options and all that. So initially the life expectancy was reduced. But now, because things have gotten a bit better, we are now able to identify our patients earlier. We have better treatments unlike before. One thing that used to really used to kill a lot of our patients in the long term used to be more of cardiovascular issues, things like high blood pressure, heart issues, and all that. So now over time, these have been mitigated. Infections used to kill people early in the disease. People have been able to mitigate that also. So now the improvement, actually the lifespan has actually improved. And I think right now it's almost 70, 75, you can actually kill that age. So in short, you can live a full, healthy life as long as you take the medicine and you're able to visit the doctor regularly. Yeah, thank you.
Yes, so what are the common causes of, death, as we're saying, lupus patients can live a long life. So what is it that can tip them over, to a bad prognosis?
So number one, infections. Actually, in the first few years of diagnosis, infection is the leading cause of death, from the data and everything. And infections from chest, UTIs, and everything. Like I said, going long term is more cardiovascular, high blood pressure, diabetes, and some of these things are a result of some of the drugs they take. But also remember that lupus on its own is also can cause
some of those things. Other things that are leading causes that might have maybe another existing condition. Patients who tend to have lupus that affects the kidneys, sometimes the outcome is actually hard. So it's always advisable that such patients have proper follow-up, because the outcome usually is not the best, especially in Black people. From the research, there's a very white people, Black people perform worse. So I think the leading cause is actually infection, but long term, it's more to do with the complications from the disease. And also some of the drugs, like if an excessive amount of steroids can cause you diabetes, pressure, and all those many things. Yeah, thank you.
Our next question is to Dr. Okongo, who will tell us about lupus and childbirth, maybe the issues surrounding the baby, just to help our patients.
Thank you,
Dr.
Sandra.
Okongo,
Thank you, Sophia. I think Sandra had asked about neonatal lupus. I actually had a slide on the same, but I removed it because of time. This is rare and usually results from transfer of what we call antibodies from the mother into the baby while still in the uterus. And these antibodies can cause symptoms. Usually these symptoms are very mild and transient, mostly fever and some rash that lasts for a few months and disappears completely. However, there is one serious and permanent complication called heart block, where the child has very slow heart rate. And this can be diagnosed while still in the uterus because of the ultrasounds that we do, if the person doing the ultrasound knows what they are looking for. And once that is discovered, then treatment can be offered while the baby is still in the uterus or after birth. Mainly in Kenya, after birth, we are able to insert something called a pacemaker to help the child. So that service is available in Kenya, but very few children get. And sometimes mothers who don't have lupus but have these antibodies can actually give birth to children with the neonatal lupus or heart block. So where that happens, then such mothers should, when they are tested, then usually we find they have those antibodies called anti-Ro and anti-La. So basically that is it about neonatal lupus. Julius Matiru had also asked about lupus and JIA, the difference, that is juvenile idiopathic arthritis. And I think the same thing that Eugene has answered. Juvenile idiopathic arthritis is specific disease of joints. Usually we don't have systemic manifestations, especially for a few, well, except for a few cases. Therefore, if a patient has arthritis or joint swelling or joint pain and stiffness, but they also have other symptoms like fatigue, fever, weight loss, mala rash or rash on the skin, then we will suspect they have lupus and we investigate them for the same. So basically, juvenile arthritis is a disease of exclusion. Anyone who has any other symptom must be investigated for lupus and a few others. Lastly, Elizabeth Irungu had talked about advocacy and available social support. I think this is very important, and she specifically even mentioned about support for healthcare professionals, because many of these patients, especially the pediatric, often have a bad outcome. Actually, I experienced the same just a week or so ago. And I think it is an important thing about advocacy to support these patients in terms of treatment supporters, psychosocial support for them, and also support for healthcare professionals who take care of these patients if the outcomes end up not being so good. Thank you very much.
Dr. Okongo, before you go, maybe, how do you deal with denial? Especially, you know, when you're dealing with parents, it's not like parents with children who have lupus. It's not like when you're dealing with the adult who is actually feeling the symptoms themselves. So this is an adult who has a sick child. They don't know what the child is feeling, but they can't even accept that the child is sick. How do you deal with that?
Thank you, Sophia. I think it's really difficult. And as human beings, denial is often part of our coping mechanism. It is one of the stages towards finally accepting and coping. And we do experience the same. Unfortunately, the children have to suffer because often there are a lot of other things. As one of the speakers said, management of the disease is not just a matter of drugs. You need the family support, and therefore the family must accept. There is a lot of financial implications, which usually is on the family. And so they have to accept. And unfortunately, many times, those who are in denial may postpone treatments, and they only arrive or come back later when they see that the patient's condition is worsening. So often we give them time so that they go through the process, except where obviously a patient has come in and is seriously sick. Then we just have to advise them to accept the treatment. And the issue of handling denial, I think, usually comes later. If someone is very sick, often there is, we are always given the go-ahead to give the treatment. But whether they'll accept now going forward is a different thing, which can be handled later. So usually it's just a matter of time. Yeah.
Okay, thank
and
you,
also, of
Dr.
course, we make use of the other psychologists and psychiatrists or mental health specialists within the places where we offer the care.
Thank you very much. Okay, there are many questions on disability, but I'll just allow you guys to ask Wilfried on your own. And I want to hand over to Dr. Genga to just wind up.
Sorry, may I back up? Say what? Sorry, and did you part? Sorry.
No, I was just saying there are many
Yes.
questions on disability, but I encourage the patients to ask Wilfrieda directly. And now I want to hand over to you, Dr. Genga, to just wind up maybe and just continue the session on Q&A or anything else that needs to be said.
So I think I'll leave the vote of thanks for Dr. Itau. He's one who must commend, is one who put together the team. I think this is a very, very, very excellent platform. I know there's a lot of misinformation of lupus out there. And I think more platforms like this can help raise awareness. I think a number of topics have been dealt with, from definitions to how to live with lupus, disability. That's one common question I keep being asked a lot by the patients. Maybe I can challenge some of the doctors in this forum in terms of the disability. I've noticed that NHF has packages like for cardiology, renal. Maybe it's high time, maybe we can approach the government and look for maybe a rheumatology package, so you can be able to get something better. In terms of registry, it will also go a long way, because a lot of the time people usually ask, what is the impact of this disease? And only registries where we can register a number of patients and tell them this amount of patients and this is what they're saying scientifically, can actually force the government to listen to us more. But I want to thank the patients. It's not easy taking medicine all the time. This is a very difficult disease. We are here to support you as much as possible. And I think, because in the interest of time, I'll hand over to Dr. Itau to analyze for us now. Thank you.
Thank you, Jean. Mine is to thank KNH National Hospital, University of Nairobi, especially the research department for hosting us. Special mention Dr. Amina, who has put this up together. Of course, Dr. Kinuthia, Nelson from research department, who is even here with us, ensuring that everything runs smoothly. Mine is to thank all the panelists for taking time, coming to join us, for taking time to make the presentation, for answering the questions. Mine is to thank the Patient Society, to thank Rachel for her courage to come out and talk to us, to thank all the attendees for being patient with us, for listening to us. I know we have many questions we are not yet answered, but we'll try and continue to answer them even after the program is over, or where possible, they can ask through the various speakers in their own capacity. So asanteni sana. It's been an awesome day. It's been good to put lupus back to the map on its own day today for World Lupus Day. Once again, to also invite all of us, the medical workers. We have a symposium at 7 o'clock to continue celebrating this World Lupus Day, and to continue with intention of educating ourselves, reminding ourselves, and knowing more and creating more awareness about lupus. So thank you very much. In the interest of time, we are going to close now, and hopefully we'll see each other again in the course of time, and to also celebrate Lupus Day next year and have other agendas and to look at it. So for the medical colleagues, please see you at 7 o'clock. Asanteni sana na kwaherini.
Thank you, Dr. Itao.
Thank you, Dr.
Thank you
Itao.
for organizing.
Thank you all. Asanteni.
Bye, everybody.
Much appreciated all.
Thank you.
Bye.
Bye.
Bye. Bye.
Thank you.
Thank you too. Thank you, Doc.